Hey guys, Miss Hill here, and I am back to finish your lecture on Individual Module 5.3. And we left off last time at the psychological adaptation slide, and so we're going to start there. So in the postpartum period, moms have to go through a period of psychological adaptation. And there are three different phases here that we recognize. One of those is the taking in phase. This is where mom is very reflective on her labor process. She's very reflective on the things that have happened during labor and delivery, and she has a lot of dependent behavior. She's depending on people to help her with the baby. She's dependent on people in terms of helping her with self-care. This is sort of the period where she's taking everything in that has happened. The taking hold phase is the phase where mom begins to accept her responsibilities. She begins to take care of herself, not needing so much self-care help from other individuals. She begins to accept the responsibilities of taking care of her baby without help from outside individuals. And this is a really teachable stage. It's important to be able to recognize this stage as a nurse, because here is where mom will more likely learn and retain the information that you're trying to teach her. And then moms go through a letting go phase. This is her accepting her new role as a mother, and she begins to relinquish the singlehood that she had, or maybe she begins to relinquish the life that she had as a mother of only one child. All moms will move through these stages at different paces, but they do tend to happen in this order. Really quickly, some postpartum pharmacology. We know that oxytocins are given during the postpartum period to help prevent hemorrhage. So we run some Pitocin on moms after the delivery of the placenta. If moms experience postpartum hemorrhage, then they may receive some Methergin, some Ergotrate, or some extra Pitocin boluses. Tylenol 3 is good for pain, Percocet as well. Mom may receive the rubella virus vaccine, because if she is susceptible to the rubella virus, then she's going to receive that MMR vaccine post-delivery, because it's a live vaccine and she cannot receive it during pregnancy. If mom is Rh negative, she may require a RhoGAM injection if the baby is positive, and we want to do that within 72 hours of delivery. Some moms may need some Ambien to help them sleep, and then contraception is also important for moms prior to them leaving the hospital. We always want to ask them what they plan to do contraception-wise. And if they are breastfeeding moms, we have to be careful about what kind of contraception we are prescribing to them. Moms that are breastfeeders are only allowed to, it's only really safe for them to take those progesterone-only contraceptives, such as the mini pill, Micronor, the Depo shot, and there are a couple of IUDs that are okay as well. Client education-wise, we got to cover a whole lot of things with these moms prior to discharge. And remember, we only have them 24 to 48 hours. We got to teach them how to do self-care, so basic hygiene of their perineum, their breasts. We got to teach them about their medication, sleep, rest and exercise, and those things differ depending on whether they had a vaginal birth or a cesarean birth. We got to talk to them about sexual activity and contraceptive use. We need them to know what their return of ovulation is between lactating and non-lactating women, when their menstrual cycle will return. The signs, excuse me guys, signs of postpartum depression. What does that look like for a mom? They need to know the difference between depression and blues and what should be reported. And they need to not feel judged for, if they need to report things. Abnormal signs and symptoms are important for moms to recognize so that they can report those back, because we aren't close by watching them once they go home. They need to know how to do basic infant care and access community resources that are necessary for them to be successful as parents when they go home. So those moms who need WIC or need transportation to their newborn follow-up appointment, all of those things they need prior to going home, and their education pieces that are very important in terms of making sure that we meet our outcome of healthy mom, healthy baby. Some of the most common postpartum issues that we see are hemorrhage. That should be no surprise to you at this point in this course. Infection and hypovolemic or septic shock. And all of these are preventable, and that's partly what make these issues so scary, is because we as nurses have to be excellent assessors so that we can prevent complications if these things occur. And we want to be able to recognize them right off the bat so that we can mitigate any problems from these things. There are some postpartum high-risk factors that we need to go over. Hypertensive disorders, pre-gestational, gestational, preeclampsia and eclampsia. Also, there's HELLP syndrome and DIC, so lots of things included under hypertensive disorders. Diabetes, whether mom's a 1 or 2 diabetic, if she's got gestational diabetes. Moms with cardiac disease. Factors that can cause overdistension of the uterus are postpartum high-risk factors. Moms with polyhydramnios, multiple fetuses, macrosomic babies. Placental abnormalities such as abruptios, previas, or retained products of conception or placenta. Dysfunctional labor, moms who are who precept or have that precipitous labor, moms with a prolonged labor or dystocia during labor. Extended period and stir-ups. So these moms have pushed for long periods of time during the second stage, and they're at even greater risk for thrombophlebitis because we've had their legs up in a lithotomy position for long periods of time. Moms who are substance abusers or the adolescent mother. All of these different individuals are people that have high-risk factors in relationship to the postpartum period. So let's talk about hemorrhage really quickly. Hemorrhage is a blood loss of 30% or more, so 500 to 1,000 mLs. Hemorrhage can be immediate postpartum, or it can be delayed. It can happen even after mom goes home. It's the #1 cause of mortality worldwide, which is huge. It's the #1 cause of mortality for postpartum women as well. Some different causes of hemorrhage are uterine atony, so the uterus that does not clamp down, moms with placenta issues such as previas or abruptions, lacerations that don't get fixed after delivery. So it might be a mom who has a cervical laceration that was not seen by the MD, and then a nurse who didn't assess the lochia appropriately, and then we ended up with a severe hemorrhage. Moms with retained products of conception, moms with the DIC, hematomas, uterine inversions, or subinvolution. All of those are causes of hemorrhage, and obviously that's not an inclusive list, but one of the probably more frequent causes of hemorrhage is uterine atony, and that's the most preventable cause of hemorrhage, because the one thing that we can do to prevent this as nurses is rub and massage that boggy fundus. That would be our priority intervention, and the majority of the time, massaging the fundus works in terms of firming it up and stopping the bleeding. We manage hemorrhage through treating the signs and symptoms of hypovolemic shock. We give the LR bolus and normal saline to increase blood volume. We give medications such as Pitocin to cramp the uterus down, Methergin to do the same thing, Ergotrate, blood transfusions if that's needed, plaqued red blood cells. We treat and we cause the bleeding, and we note the amount. So, for example, if it's a cervical laceration, then we would want to call the doctor back, and he'd need to go in and stitch that up. If it's retained products of conception, that mom's going to need to go back to the OR and have a D&C so we can treat the cause of the bleeding. And if all else fails, moms potentially may have to have a hysterectomy. Always we want to repeat the complete blood count so we know where our hemoglobin and hematocrit stand. Just a note here is that Methergin is often used to expel products of conception that have been retained, and also used for hemorrhage, so we can use that in a couple of different ways. Adverse drug reaction in relationship to Methergin, and also diarrhea is a really common side effect. Oxytocin is our first line drug for postpartum hemorrhage. It's something that everybody gets once their placenta is delivered. That is our first line drug. If that doesn't work, then we throw in some Methergin. But some side effects of oxytocin are urinary retention and water intoxication, which can cause fluid and electrolyte imbalances. So mom may end up with some hyponatremia, some hypokalemia, hypochloremia, lots of different low electrolyte levels. And here's your, oh my, I've lost the vital signs. This is how we manage hypovolemic shock. So we give some oxygen at 100%. We give medications such as dopamine and norepinephrine to keep the blood pressure up. We give isotonic IV solutions, LR, normal saline. We get lab results. We got to monitor the blood and ABG, CBC count. We want to transfuse blood and blood products. We want to make sure that we've got accurate vital signs, including level of consciousness. And then obviously we want to support and warm the mom if she's going through these hypovolemic shock signs and symptoms. Postpartum infections are something that you might commonly see in the postpartum period, and sometimes they can be caused by E. coli, which is one reason why we want moms to wipe front to back. They can be caused by group beta strep or staphylococcus. Moms that are at risk for postpartum infections are those that have had prolonged rupture of membranes, retained products of conception. They may have experienced some type of contamination in regards to invasive procedures. So, forceps delivery or a delivery table that was unsterile, a C-section that introduced an intra-abdominal infection somehow. Moms who are malnourished are also at greater risk for postpartum infections. Moms that are anemic, immunosuppressed, have pre-existing conditions, or have skin issues. Puerperal infection clues are things like foul-smelling lochia should clue you in to a mom that may be experiencing endometritis. If you have an infected suture line, obviously you'll be able to assess that through your Rita assessment. Moms who have no bowel sounds and a rigid abdomen may be experiencing peritonitis. Ladies with positive Homan sign might be having thrombophlebitis. And sore, engorged, hot, reddened breast tissue would clue you into infections that are of the breast, such as mastitis. So all of these are some of the different assessment signs that you may see with people that have these types of postpartum infections. When we provide nursing care in the postpartum period, we always assess for signs and symptoms of infection. We obtain samples for culture insensitivity before antibiotic treatments. We make sure we're performing good hand washing and teaching good hand washing to mom and family members. We teach correct perineal care. We maintain sterile technique procedures as required. We help keep mom hydrated. Hopefully we can get her to intake 3 liters a day. We encourage a high protein diet because we know that helps with healing, proper wound care, and then antibiotic therapy based on that culture and sensitivity. So here are a few of the nursing diagnoses that you may see in relationship to the postpartum period. Health-seeking behaviors, fear, altered family coping, pain, fluid volume deficit, disturbed sleep pattern, imbalanced nutrition, less than body requirements, impaired urinary elimination, ineffective tissue perfusion, impaired parenting, and ineffective sexuality patterns. All of these are nursing diagnoses to consider. You can read through the related to and apply an as evidenced by in your own spare time to help you meet your objectives. But these are just some different ones that you should consider when thinking about the postpartum period. And here are some of our nursing interventions specifically for the first 24 hours postpartum. We want to relieve discomforts. We want to assess those afterbirth pains and help mom to understand what they're all about and how to relieve them. Talk with her about muscular aches, episiotomy care, perineal exercises such as Kegels. Talk about cold therapy and the sitz bath in relationship to the perineum. So cold therapy initially for the first 24 hours or so, and then warm therapy such as sitz baths for the perineal area to increase blood flow and healing afterwards. We want to assist mom with perineal care in the first 24 hours, but we want her to progress to being able to provide that perineal care by herself as well. We want to ensure that she gets plenty of rest because that also helps with healing, and we know that moms are exhausted and fatigued after they come through labor. The more well-rested we are, the better mentally and emotionally we can provide for our newborn, and the better off we are ourselves. We want to make sure she's got adequate fluid intake and she stays nice and hydrated, because that helps us to prevent constipation. We might want to be given some extra meds to help prevent that constipation, such as Colace or milk of magnesia. We want to be encouraging ambulation to help prevent constipation and also to help prevent deep vein thrombosis. We can help prevent hemorrhoids also in some of the same ways we can help prevent constipation through medication, Colace, milk of magnesia. All those things help a mom to not have to strain so hard and will prevent hemorrhoids. And we also want to prevent breast problems. And one way we do that is by teaching mom the appropriate way that her baby should be latched on, ensuring that she's got good breastfeeding support if she's a breastfeeding mom, ensuring that she washes her hands prior to feeding her baby. And if she's a non-breastfeeding mom, then we want to explain to her how to prevent breast problems in different ways, such as applying cabbage leaves, applying ice packs, binding her breasts up, not letting anything stimulate them to that would require a milk letdown reflex to occur. And some of our goals for nurse care planning whenever we are considering the mom in the postpartum period is to promote hemodynamic stabilization. We want to provide nutrition and hydration for those moms, promote safety for mom and baby, promote comfort and pain relief, prevent complications by utilizing good assessment skills and great education techniques, promote family attachments and newborn bonding, and also do lots and lots of new mother and family teaching so that they go home prepared to take care of themselves and their new family member, which will help us reach our ultimate goal of safe mom, safe baby. So our expected outcomes: we want the mother's physiologic and psychological well-being to have been supported throughout her labor and delivery process and the postpartum period. We want her to express relief and comfort in using the pain scale and with pain relief measures. We want new parents to demonstrate newborn care skills, and we want them to have the adequate opportunity to form attachments with the new family addition really prior to going home. And now we are going to move on into postpartum depression and mood and affect. Here are your learning outcomes. And initially, what we want to talk about is maternal role attainment. Maternal role attainment usually occurs in the first 3 to 10 months after birth. It occurs for all mothers because of their different experiences. But we're going to talk about these 4 stages really quickly. The anticipatory stage occurs during pregnancy. This is when the mom looks to role model herself and her mothering behaviors after other individuals. So she has an idea in her mind of who or someone that she thinks is sort of the ideal mother, and she starts to role model herself after that person. And then we move on to the formal stage, and this happens when the child is born. And during this stage, moms are influenced by other people. Their actions are guided by what other people expect. If their moms or their grandmothers expect that they're going to bottle feed their baby and they really want to breastfeed, this is the stage where they are really heavily influenced by what other people expect them to do or want them to do. And then the informal stage begins when the mom starts making her own choices about mothering. She develops her own style that works for her and her family. And then she's really not ashamed about that. And she moves on into the personal stage, which is the final stage, where she is very comfortable with herself as a mother. There are a lot of factors that play a role in maternal role attainment, and those include things such as age, personality of mom, support system, her relationships, if she has any types of anxiety or depression, what her previous experiences are, her socioeconomic class, and then the infant behaviors can also play a role in maternal role attainment. The normal presentation in the postpartum period come along with a lot of challenges for the postpartum mother. She struggles with time for herself. She struggles with confidence in her new role. She's fatigued. She's got an overwhelming sense of responsibility. She has guilt in terms of not being able to have as much time with her other children if she's a multip. And then she possibly may be experiencing challenging infant behavior. So she may have a baby that cries all the time no matter what she does. And that perpetuates a cycle where you have no time for yourself, you have no confidence in your new role, you're continually fatigued, your sense of responsibility continues to overwhelm you, you have less and less time for your other children, and all of those, when you have an infant that has that challenging behavior, it causes all of these other areas to be really worse. And this is often an area where moms tend to not express themselves or how they feel because no one wants to go tell anybody that their baby is a terrible baby and they just can't do it anymore. So that's all something to keep in mind and to also educate moms about in terms of the challenges that she may experience when she goes home. We also have to develop some family attachment whenever we bring a new addition into our family fold. We've got to develop a level of trust, and this happens to develop in terms of what our life experience has been in the past. Some people have no problem developing a level of trust with individuals, and other people do have a serious problem with developing a level of trust. This level of trust goes both ways. That the newborn baby has to develop a level of trust with the parents, and the parents have to develop a level of trust with other individuals in the family in terms of caring for the baby. Dad may have to develop a level of trust with mom for taking care of the baby, and the other way around, vice versa. There's a level of self-esteem that also has to be developed. Moms and dads have to experience a level of confidence that will boost their self-esteem, knowing that they are going to be able to do this. They can take care of this baby appropriately. There's also the capacity for enjoying oneself. It's very hard to enjoy things when you don't have time for yourself. So it's a new sort of ride whenever you've got another life that depends on you. You have to find new ways for enjoying things and enjoying yourself with this new addition. Adequacy of knowledge about childbearing and child rearing. Previous experiences and beliefs of the parents are heavily contributed to what their knowledge is in regards to childbearing and child rearing, and it will influence the way they set forth in terms of a development of family attachment for new additions. And then the prevailing mood or the usual feeling or tone of the mom. Is she angry? Is she depressed? Is she sensitive to others or herself, or, etc.? That prevailing mood will set the tone and influence the development of family attachments. And then reactions to the present pregnancy. Is the pregnancy wanted or not? Was it a smooth pregnancy? Was it a terrible pregnancy? What type of life events happened during this time period? All of those things will influence the development of how the family attaches to the new addition. There are some initial maternal attachment behaviors that we should go over. Once the newborn is here and born, there is a progression of touching activities, and they can vary from minutes to days depending on your experience and how confident you are as a mother. The mom really goes from a period of where she just might place a finger on the baby, touch its hand with a finger, and then she might lie her whole hand on his back. And then she may actually take him and snuggle him up really close until she progresses to a point where she is holding the baby in a position that we call in face. And this is a position in which mom spends a lot more time and interest in the newborn. She's got him sort of face to face. She's got eye contact with him. She communicates with the newborn through high-pitched sounds and words, baby talk. She relies heavily on her senses, sight, touch, hearing, and smell. And then she goes through an acquaintance phase. This happens for the mom and the baby. The mom has to get acquainted to the baby and what the baby's behaviors are, and the baby has to be acquainted with the mom. And this is a phase. They have to get used to each other, acquainted to each other. Then we have a phase of mutual regulation. This is where mom and baby sort of struggle with control. Who's going to win? There's got to be a balance that is obtained between the mom and the baby's needs, because negative feelings from the mom can begin to surface here, but they usually go unspoken. Moms don't tend to express negative feelings about her newborn baby because socially, really, that's unacceptable. And so they bottle that up and keep it inside. But here, the mom and the baby struggle for that control, and they have to obtain that balance between the baby's needs and mom's needs. And the goal of all of this is reciprocity. We really want the relationship to be a satisfactory one for both mom and baby. We want mom to feel a sense of fulfillment, and we want the baby's needs and wants to be fulfilled as well, so that baby can move through normal developmental stages appropriately. The father-infant interactions are also very similar to the mother. Engrossment is a term that means a characteristic sense of absorption or preoccupation and interest in the baby. And usually dads demonstrate this really early during contact with the newborn. But we tend to have a really wide range of differences in Western culture regarding involvement in father-infant interactions, because some fathers may not be present at all, and some fathers may be, there with, hip attached to mom with her step by step and side by side the whole time. Siblings and others in the family also have to experience different types of infant interactions as well. There are social settings and individual personalities that play a role in how this infant comes into the family fold. Those social settings and individual personalities are significant factors in development in regards to multiple attachments when it comes to the newborn. And all of this is part of the family-centered care model. There are some cultural considerations that we also have to keep in mind during the postpartum period as well as nurses. Europeans are probably the ones that we are most familiar with. We are, very quick to want to get back to our normal life. We want a full meal after delivery. We want to get up and get a shower. We want to start walking around. That's kind of the European way. We want to get back at it. With the Islamic faith, they have a lot of modesty requirements, and we have to be very cognizant of that as nurses, because when we're in with a mom who might be of that faith, we want to be really careful and sensitive to her modesty needs. We want to make sure that when we're doing our assessment that we keep her covered well. We don't want to expose all of her at one time. If we have to assess her foot, we only want to uncover her foot and not both of her legs. African Americans tend to rely really heavily on extended family. We, as nurses, need to be aware of that and allow access of that family to the mom in terms of visitors. The grandmother tends to be relied on very heavily because she's seen as having lots of wisdom in this culture. In labor and delivery, we tend to want to limit visitors and not allow a lot of people to come back. But for people whose culture relies heavily on this type of extended family, we need to keep that in mind. They feel most comfortable when that family is there and around. So we want to make sure that we are able to accommodate those cultural needs. Orthodox Jews celebrate something called the Sabbath, and it occurs from sundown on Friday through Saturday. And during this time, these individuals will not do any work or ask anyone to work on their behalf. So, and they consider even little minuscule things work. So, for example, they will not ask you as the nurse, if they deliver on the Sabbath, they will not ask you to go get them a bottle of water. They will not ask you to help them get up out of bed and go to the bathroom. They will not ask you to turn their light on or off, or they won't press the call bell. They won't ask you to move their bed up or down. So we have to be really in tune to their needs, because they're not going to ask you for anything. So, moving on to some other normal presentations during the postpartum period. The postpartum blues is a normal presentation during the postpartum period. It occurs in about 50 to 75% of women, and it all happens because of the fluctuation in hormones that occurs. Usually it resolves in about 10 to 14 days, but the key feature of postpartum blues is episodes of tearfulness that do not have a cause. Interventions for the postpartum blues are that we just have to validate the existence that this is a normal occurrence postpartum and give these moms adequate support physically, emotionally, and mentally. There are several factors that contribute to postpartum blues. There's an emotional letdown following birth. You've carried a baby around for 9 months inside of you, and there is a feeling of fullness there. And then once that baby is born, typically moms feel really very empty. So they have this emotional letdown following birth that they really just can't verbalize or explain. They also have physical discomfort, fatigue. They have anxiety about caring for their newborn possibly. And they may have depression during their pregnancy, or they may have depression that's unrelated to their pregnancy. And also individuals who experience severe PMS are also individuals who will more than likely experience these postpartum blues. So those are some of the factors that contribute to moms with postpartum blues. And then we have moms who experience postpartum depression. This is also known as major depressive disorder with a peripartum onset. It occurs during or in the first 4 weeks postpartum, and it can last for up to a year afterwards. 3 to 6% of women experience postpartum depression, and it may or may not be associated with psychotic symptoms. Delayed treatment is usually associated with a longer duration of postpartum depression. And almost half of these individuals will continue to experience postpartum depression at 6 months postpartum or even longer than that. I recently went to a conference and they actually are now recognizing that postpartum depression can occur not only in that first 4 weeks postpartum, but they actually are recognizing now that postpartum depression can occur up to a year postpartum. And so whenever I said at the beginning of individual module 5.3 that we do a really terrible job at taking care of moms during the postpartum period, this is one of the things that goes easily missed because these moms only get one appointment after they're to leave the hospital. And we see them at 6 weeks, and then we don't see them again. And if postpartum depression can occur up to a year after they've delivered their baby, likely we have missed that as practitioners because we don't see them again. So if we don't educate them well, if we don't educate their family members well, then this can be something that progresses to a point that it's unhealthy for the mom and the baby. Postpartum depression signs and symptoms are very similar to regular depressive signs and symptoms. Moms report a feeling of living in a fog. They have an overwhelming sense of sadness. They have frequent crying, insomnia, and excessive sleeping, appetite changes. They have feelings of worthlessness, lack of interest in normal activities, persistent anxiety, and they may have some irritability and hostility towards others, including their newborn. These individuals cannot take care of themselves, and they cannot take care of the baby like you would expect that they should. And here are a few risk factors to consider in regards to postpartum depression. Prematurity, so moms who are having a first-time delivery. Moms who are very ambivalent about their pregnancy, so they may or may not have wanted it. Those moms that just act like they really don't care. Moms who have a past history of postpartum depression, a lack of social support, or a lack of supportive relationships, specifically and especially with the father of the child. Dissatisfaction surrounding herself. If you can't be happy with yourself, it's really hard to be happy with other individuals. A risk for suicide is the greatest when entering or exiting a deeply depressed state. So, for example, when moms are in the throes of their deeply depressed state, they really are too depressed to do anything in regards to suicide. They're too weak, they're too fatigued, they do not have the energy to carry out a plan. It's whenever they are first going into this deeply depressed state or coming out of this deeply depressed state that they get up the gumption and the energy to carry out a suicide plan. So we have to be able to assess for that and educate family members about that. There is a greater suicide risk for those who have a history of postpartum depression. And moms that attempt suicide do this because they have a suffering that is unparalleled to anything you can understand if you've never been through this. And they perceive themselves as a threat to the newborn and think the only way that they can remove themselves as a threat to the newborn is to commit suicide. The more specific a mom's plan is in terms of committing suicide, the greater the probability that she will actually attempt that plan. And then from postpartum depression, we actually can move even farther down the continuum into postpartum psychosis. And this is considered an emergency. These are postpartum mood episodes that have psychotic features attached with them. So, for example, agitation, hyperactivity, insomnia, irrationality, difficulty remembering or concentrating, moms with poor judgment, moms that experience delusions or hallucinations, which are usually related to the infant. There is an increased risk for first-time deliveries, especially and also especially with moms who have a prior history of postpartum depression, regular plain old depression, or bipolar disorder. This is a very rare illness, but it does happen. And the good thing here is that 95% of these individuals can recover with proper care and treatment. However, there is a high rate of occurrence, so we have to pay super close attention to these people. It is considered an emergency if a mom has postpartum psychosis because of the risk of suicide and infanticide. These individuals have delusions and hallucinations that will actually support their perceptions that the infant or the mom should not be allowed to live. And that's how come we see these suicide, homicide, or infanticide stories in the news. Is because someone has experienced this postpartum psychosis and it either wasn't recognized soon enough or not treated properly in order for mom to recover and keep mom and the baby safe. We got a few screening tools that we can use for postpartum mood disorders. You should be familiar with at least one of these, the Edinburgh Postnatal Depression Scale. That is the tool that you guys used in clinical, and the biggest thing to note about this one is that the number 10 items scored on this tool has to be looked at separately and scored separately because it's a suicide question. The Postpartum Depression Predictors Inventory is also another screening tool that we can use in postpartum mood disorders, and you can check that out in your book. We have several treatments and therapies that we use whenever we diagnose a mom with any of these mood disorders. So depending on what the doctor sees fit, he may put mom on some SSRIs, some fluoxetine, lithium, antipsychotic drugs. We may refer her to support groups. She may receive electroconvulsive therapy if she has progressed to a psychosis state. Psychotherapy may be warranted, and even hospitalization if she's a danger to herself or the baby. Some nursing diagnoses to consider in regards to postpartum mood disorders would be ineffective individual coping, a risk for altered parenting, risk for violence. But ultimately what we really want is the signs of depression to be identified and interventions to be prompt and on top of things. We want the baby to be cared for effectively by the people who are supportive to the mom until the mom can provide that care on her own. We want the mom and the newborn to remain safe, and we want everybody to be successfully integrated as one family unit. And that is the end of individual module 5.3. This is lecture 2 for this module. Thanks for listening.